Good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled Molecular Testing for GI Pathogens, Cost Effectiveness, Clinical Impact, and Lab Implementation. My name is Andrew, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. This webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen, and if you require any assistance, please contact me at any time by using that chat panel. And at this time, all participants are in a listen-only mode. And please note that this event will be recorded and made available for future download. Live audience members today can apply to receive a professional acknowledgement for continuing education or PACE credit issued by the American Society for Clinical Laboratory Science through our exit survey at the end of today's session. And now I'd like to thank Nanosphere, who is sponsoring this live webinar today. Nanosphere is dedicated to enhancing medicine by providing targeted molecular diagnostic tests that can lead to earlier disease detection, optimal patient treatment, and improved healthcare economics. Their platform, the VERIGENE system, enables clinicians to rapidly identify the bacteria and viruses responsible for some of the most complex, costly, and deadly infectious diseases. Currently, the VERIGENE test menu targets infections of the bloodstream, respiratory tract, and gastrointestinal tract. And now, I'd like to introduce our first speaker for today's event. Dr. David Pieper earned his MD and PhD degrees from Yale, graduating in 2007 and 2008, respectively. After graduating medical school, he entered into the clinical pathology training program at Yale New Haven Hospital in the Department of Laboratory Medicine at the Yale School of Medicine. He served as chief resident before completing a fellowship in medical microbiology. Dr. Pieper is now assistant professor of laboratory medicine at the Yale School of Medicine, where he serves as the director of medical microbiology for Yale New Haven Hospital. And our second speaker for today, Marilyn Mitchell, is microbiology supervisor at Community Regional Medical Center in Fresno, California. In 2000, she completed a master's degree in molecular biology from California State University at Fresno. Since 2012, she has been the hematology instructor at California State University at Fresno to help prospective clinical laboratory scientists get a solid background in a needed requirement. And now, without further ado, I would like to hand the mic over to Dr. David Pieper. Dr. Pieper, you can begin your presentation when ready.
Thank you for the introduction. Just want to make sure everything is appearing okay.
Perfect, yeah.
Great. So today I'm going to talk about, provide a basic overview of some of the diarrheal syndromes, symptoms, and pathogens that we're familiar with, talk about the traditional diagnostic approach, its strengths and weaknesses, and then talk about the potential role for molecular diagnostics for stool pathogens, some of the benefits of molecular diagnostics, as well as briefly discuss some of the financial case for moving to a molecular solution. We know that enteric pathogens are a burden, but until you really review the statistics, it becomes quite sobering about how foodborne pathogens affect healthcare in the United States, causing estimated over 9 million illnesses, 56,000 hospitalizations, and over 1,500 deaths a year. Overall, costing the healthcare system, the workforce, and once you calculate life years and the associated mortality, about $77 billion per year in the United States, ranging from $200 to $34 to $2.8 million per case. When we look at the potential pathogens that we're talking about, I've taken from the emerging infectious disease from the CDC and excluded some of the toxin-mediated diseases, but really looking at those organisms that are causing disease that we routinely test for in the microbiology lab, and the number of illnesses and hospitalizations and deaths that are associated with each of these organisms, from a high of over 5 million for norovirus to over 1 million for salmonella, really conveying the clinical significance of foodborne infections and enteric pathogens. When we think about enteric pathogens, we have a variety of different organisms that can cause disease through a variety of different mechanisms. Bugs like B. cereus, Clostridia perfringens, Staph aureus, which have preformed toxins that cause an abrupt onset after ingestion, and typically a self-limited disease for which we don't typically do any testing because the disease is sufficiently not severe and not sufficiently long-lasting. At the extreme other end, we have some of our parasites that have a variety of different mechanisms of disease, but typically cause disease over a week after ingestion, and for which we have some more specialized testing, such as Giardia cryptoantigens, potentially PCR, and open parasites exam or modified acid fast staining. In the middle, we have really where I think the bread and butter and the bulk of our workload is on our typical bacterial pathogens that typically invade tissue, destroy tissue, and or produce toxins once they have entered into the intestinal tract. Things like Campylobacter, STEC, Salmonella, Shigella, Vibrio, Yersinia, where onset of disease can be days after ingestion, with or without a prodrome, with or without blood in the stool. They can be self-limited, but you can also have prolonged shedding, and we ultimately end up doing a stool culture for these. We all are probably very familiar with C. difficile, its toxin production, but in most laboratories there's a separate workflow for that because of the unique demographics and epidemiology of that particular pathogen. Similarly, we have our viral pathogens such as norovirus, rotavirus, etc., that also have a separate workflow. The clinical problem is that when patients have, self-limited diarrhea 1 to 2 days, typically no diagnostic studies are performed or nor warranted. But as diarrhea or nausea-vomiting diarrhea persists after multiple days, patients have the potential to become dehydrated, more severely ill, and that is when diagnostic testing is thought to be undertaken. The problem is that the clinical syndrome for many of the different pathogens with different significant and treatment indications and, importantly, strong contraindications is essentially the same. A prodrome of fever, chills, and malaise, onset of diarrhea with or without blood, cramping, occurring 3 to 7 days after exposure, lasting potentially 3 to 7 days in an otherwise immunocompetent host. And so these are the circumstances under which medical providers ultimately undertake lab testing, and classically the stool culture. Why is testing performed under these circumstances? Well, why test in general? There can be specific interventions that are undertaken, so that the identification of Campylobacter may lead you to consider a certain subset of antimicrobials versus the identification of Salmonella or STEC, for which you may not want to undertake antimicrobial therapy. You may want to use antimotility agents in a patient to allow them to obtain symptomatic control, but these are specifically contraindicated for some of the pathogens. Additionally, because some of these pathogens are important in the hospital, and you want to prevent nosocomial spread for hospitalized patients, different contact precautions may be appropriate. Another reason to test for these things would be to further limit the diagnostic workup, so that if you can identify an etiology of the patient's diarrhea, you don't have to pursue the $1 million workup necessarily. And finally, many of these organisms have tremendous public health importance for identifying foodborne illness outbreaks with potential public health consequences, as well as identifying particular individuals at high risk of transmission, such as kitchen staff. So in 2001, which admittedly is 14 years ago, the IDSA released their guidelines on the evaluation and treatment of patients with diarrhea. And so that they recommend evaluating severity, duration, through history, physical exam, etc. And then for patients in the community, primarily test for Salmonella, Shigella, E. coli 0157, potentially C. difficile as well. For patients who have nosocomial diarrhea, more than 3 days in the hospital, primarily test for C. difficile, but consider others. And for those with persistent diarrhea, to then begin to consider more seriously the possibility of parasites or others if immunosuppressed. The CDC subsequently recommended in 2009 that all stools should get Shiga toxin testing for non-0157 STEC, since that is a gap in the IDSA guidelines. As I mentioned, these are getting to be quite old, and they're currently being revised, and we'll anxiously await the revisions as they come out. But this is kind of where we are right now. The diagnostic problem, though, is that for providers, test ordering patterns aren't necessarily uniform. We know that not everyone always follows the guidelines, both under-ordering and over-ordering. Pathogens can demonstrate seasonality, but can be seen also year-round, so that if someone overemphasizes seasonality, they may miss something. The epidemiology differs, so that you may be ordering something or not ordering something depending on what your patient's epidemiologic risk factors are. And it's very difficult to order all of the tests that's necessary to cover all of the appropriate pathogens for your patient, because it's typically not just one test, not one stool culture. You may have to order a variety of tests. For the lab, this presents challenges because we often will have to use specialized media or tests for the identification of enteric pathogens. There's a whole host of media that I'll go over briefly that are not used for really essentially any other specimen type. And finally, the incidence of a single pathogen in the laboratory at a single institution may be low, so that there is a tendency to maybe try to exclude that from the diagnostic evaluation since it's perceived to be very low yield. This applies also to providers who think like, I don't particularly need to test for Yersinia because I've never seen Yersinia, or I infrequently see Yersinia, so it's probably not that. Same true for Vibrio, potentially viruses. Additionally, there are some epidemiologic data about patient age, or the presence or absence of blood, or presence or absence of antibiotic exposure that could push you in one direction or the other in a comprehensive test order. But if you strictly abide by these rules, some infections could potentially be missed. So when we look at our current workflow for the evaluation of stools and the full spectrum of pathogens that could be evaluated, the summary in the parlance of our time is it's complicated. So that we have a whole host of augers that are used primarily just for stool pathogens, a variety of different incubation conditions from anywhere from 24 hours to 72 hours with different aerophilic conditions, such as for Campylobacter. All of these have a variety of drawbacks, such as the inability of our SMAC plates to recover non-0157 STECs. We all know that on our salmonella plates, we may have problems with our hydrogen sulfide producers appearing black, so that we have to rule out salmonella quite frequently, or our non-lactose fermenters, so that we have to rule out Shigella from these plates. For C. difficile, there's controversy about the ideal algorithm, and is this something that we want to be testing on everyone, outpatients, inpatients, et cetera. And for our viral assays, right now, they're mostly just standalone tests or expensive send-outs that we may not necessarily be testing for. Additionally, we have to do a lot of confirmatory testing for all of these bugs to make sure that we've made the right identification. The consequences of this complex workflow are several-fold. So first, there's cost associated with this. We've got our plates, our antigen tests, and then our standalone molecular diagnostics for, say, C. difficile or norovirus or rotavirus that all together add a lot of cost. Importantly, from the laboratory perspective, it's extraordinarily labor-intensive with multiple small steps that require a lot of hands-on time. This is made more pronounced by the non-specificity of these culture methods, so that our hydrogen sulfide producers and our non-lactose fermenters, we see a lot more of those in stool than we do of actual pathogens. So there's a lot of effort for our negative culture. And so what is the result of this? The result is that we have lots of what we call work in process, where we've got a lot of hands-on time for essentially no effect at the end. And additionally, laboratories then consider a lot of efforts to cut waste and simplify our culture tests by employing rules or limiting further evaluation. But as I mentioned, that's actually going to miss things. So at our institution, we've historically looked at patient age and the blood in the stool for when we're going to be performing a Shiga toxin a test. And looking at this study from J. Micro a couple years ago, they found that the mean age of patients with non-0157 STECs was nearly 20 years old, and only approximately 60% of patients with non-0157 STECs actually had blood in their stool. So these would be missed by a rule-based approach to testing. So that leads into the potential solution, which would be molecular assays. And so I think the question is, what are the factors in the laboratory that promote the adoption of molecular assays? And my thinking is that these really need to be clinically significant infections. The current methods should be inadequate, either requiring specialized culture techniques, things like, driving why chlamydia testing was moved to nucleic acid testing very early, fastidious or uncultivable organisms, same is true largely for gonorrhea, or slow-growing organisms like Mycobacterium tuberculosis, where a molecular solution addresses each of those concerns. Finally, I think it's very important that these be definite pathogens or have a definite epidemiologic significance. Restated is a yes or no answer sufficient? So that we don't want to think like, oh, you've got a very mild case of gonorrhea. You don't want to say like, oh, you've got a very mild case of STEC diarrhea. A yes or no answer is really important and really essential for the promotion of these tests. So do enteric pathogens fulfill these criteria? Are these clinically significant? Yes. Are current methods inadequate? I think I've outlined the case why that's a yes. Are these definite pathogens or have definite epidemiologic significance? In most cases, that's yes. And for enteric pathogens, is a yes or no answer sufficient? Yes. And so is a molecular solution appropriate for enteric pathogens? And I think ultimately the answer to that is yes. So how do molecular assays compare to currently available methods? So when you're looking at the spectrum of tests that are currently available, and I've that summarized in a table on a couple slides, you want to look at the included analytes. What are you doing now? If you adopt a particular test, are you going to have to give up an analyte, or are you going to be forced to adopt an analyte that you don't particularly want to interrogate because you don't know if it's clinical utility, your providers aren't asking for it? And will I have multiple tests for the same pathogen? So for example, if you're going to adopt a universal enteric PCR that includes C. difficile, is that going to replace all of your C. difficile testing, or are you going to have a separate C. difficile test and then maintain QC and quality control and proficiency testing for two different tests? Looking at your workflow, what is my required turnaround time? Do I need a test that's random access to provide faster turnaround time, or is batch testing sufficient? Looking at my technologist and who's going to be doing the testing, do I need a moderately complex test, or is a highly complex test okay for my needs? Look at the literature to talk about the sensitivity and the specificity. The product inserts and the FDA approval information is also very useful for this. And then finally, looking at the vendor. So do I have existing instrumentation that I can add this test on, or do I need new instrumentation? If I add new instrumentation, are there other assays I would like to bring onto the same instrumentation? So when we look at the current market for enteric pathogens, nearly all of the tests available include what I would call the core pathogens, Salmonella, Shigella, Campylobacter, and Shigatoxin-producing E. coli. There are a couple tests that add C. difficile into the mix. There are several tests that add other bacteria, viruses, or parasites. There's some that are highly complex, requiring offline extraction and processing. Others are moderately complex with onboard extraction. Some have integrated extraction, as I said. And then there's a highly variable throughput and workflow. So what are those things that you're looking at for a test? And that's something that only you can answer. So when we look at the currently available IVD-labeled assays for enteric pathogens, I've kind of summarized those on the left. They all include core pathogens, except for the Cepheid tests, which are predominantly for C. difficile and norovirus, but I've included for the sake of completeness. We look at the VERIGENE, the FilmArray, the BD Max, ProDes, and Luminex. Do they include C. difficile or not, or do they have a separate test that's for C. difficile, such as VERIGENE and BD Max? Are they included, such as in FilmArray or Luminex? Do they include viral pathogens, such as norovirus and rotavirus? Do they have other pathogens, which are summarized at the bottom? For VERIGENE, we have the core pathogens, norovirus, rotavirus, and then Vibrio and Yersinia. For FilmArray, we add a variety of other bacterial pathogens, a variety of different flavors of E. coli, several more viruses, as well as some parasites. For Luminex, we kind of meet in the middle. The underlying technology, and the importance of the underlying technology is that this drives the degree to which multiplexing is possible, as well as the CLIA complexity, so that our traditional real-time PCR assays are not going to be able to have as high a degree of high-order multiplexing as some of our other tests, such as the VERIGENE with nanoparticle array detection, which is also moderately complex. So, this is where you want to look and think about what test is going to best meet your needs. And why is this something that you should also consider? So why rapid molecular testing for community-acquired diarrhea? So number one, the literature is quite established that among the tests that are on the market, there's increased sensitivity or overculture for common pathogens. You have reduced time to identification. And importantly, and I think this is really one of the key selling points to me, is that the Shiga toxin-producing E. coli is twice as sensitive as our broth EIA testing for STECs. And so I think the literature shows that we're really missing a lot of STECs, and I'm kind of worried about that and providing that level of care to my patients. From a workflow perspective, we've outlined some of the problems with the current workflow. By moving to a molecular solution, you reduce hands-on time tremendously, and then you also allow those negatives to be sent out basically immediately. For health economic reasons, the cost on average between reagents and labor of a positive stool culture is over $400. And if you move to a more molecular testing with better turnaround time, you can save a lot of isolation days in your hospital with an associated cost of that, also allowing the outbreak investigation to be undertaken earlier. Finally, why particularly to consider norovirus testing? It's the most common foodborne illness in the United States with a many number of cases. Viral enteritis, not otherwise specifies, is actually the most common diagnosis code for infectious enteritis. And then finally, if anyone's ever had a norovirus nosocomial outbreak, the costs associated with that can be tremendous. Thinking about other pathogens, we have on the VERIGENE panel, we also have the rotavirus, which may likely be under-tested with a low sensitivity method. We also have things like Yersinia enterocolitica, which has a lot of clinical overlap with Shiga toxin-producing E. coli, but there are tremendously important differences in the clinical and management differences between STEC and Yersinia. And then finally, looking at CDC data, Vibrio has actually been the most common, the greatest increase year over year of bacterial infections in the United States. And I think we're under-testing for Vibrio potentially. So the elephant in the room with a lot of these molecular tests is what about the cost and what about the financial assumptions that we can make. And so I've made a very conservative assessment of the potential financial implications of adopting a molecular test, looking at the factors that could affect our reimbursement income. And some of the principal factors there are going to be the percent of stool tests that we do on outpatients that we get reimbursed for, the percent that are public payers, the degree of public reimbursement, and the amount of private reimbursement we may get. By no means am I saying this is the only way to go, but when you look at the available CPT codes, if you were to implement the VERIGENE test, I think a reasonable approach would be to try to use CPT code 87506, which is an infectious agent detection by nucleic acid, multiplex gastrointestinal pathogens, 6 to 11 targets. In most states, the reimbursement for this is $290. I'm assuming that we actually don't get any credit for the financial savings from workflow. As much as that's one of the factors motivating me, it's going to allow my staff to be doing other things. I'm not going to be laying off staff, and so there's really no net gain from that. Looking at the VERIGENE enteric pathogen list price, it's $85 list, but your pricing will vary. And so for the purposes of my next couple slides, I've assumed a discounted price of $80, but you really need to talk to your VERIGENE rep to see where your pricing would be based on your volume. I'm further not considering the equipment cost. You may have the existing equipment for other tests, or you may pursue a separate lease or capital purchase agreement. When we look at conventional stool cultures, assuming a volume of about 2,000 tests per year, based on some of our internal data in terms of ruling out Shigella, ruling out Salmonella, the number of IDs that we do that are reported versus not reported, I came up with a cost of about $27,000 in reagents alone for all of our stool cultures with about a 5% positive rate. These costs are not Yale New Haven costs, but really I pulled those from the GSA Advantage government website, which is a publicly available pricing, so everyone can look at that. When we look at the VERIGENE cost, with, as I mentioned, my assumed $80 cost per test, for these same 2,000 stools, we would spend $160,000 in reagents alone. However, when we look now at the annual total reimbursement for those 2,000 tests per year, and I've broken the three tables out, each looking at different degrees of private payer reimbursement, your public payer mix, as well as if your testing is done predominantly on outpatients or on inpatients. And keeping in mind the $160,000 supply cost, we look to see really only under extreme conditions does this not become a net revenue producer for the lab, namely when you're doing testing almost predominantly 75% of your testing on inpatients. So long as you're in the 50-50 inpatient-outpatient range, this becomes a net positive for you financially, but I think most importantly a net positive for your patients and a net positive for your laboratory workflow under those conditions. And as you test more outpatients and as you see higher private payer reimbursements, then it becomes more of a net positive outcome for you. So why do I ultimately favor a molecular solution for stool pathogen testing? I think you get faster turnaround time so that clinicians can make more timely clinical decisions. You have improved sensitivity over conventional methods, especially for our non-0157H7 Shiga toxin-producing E. coli. Importantly, you get improved specificity, so you aren't ruling out your black colonies, and you're not looking at all of your non-lactose fermenters on your HE or XLE augers. And at the end of the day, you have tremendously improved workflow in the laboratory, so that you have decreased hands-on time to free up your med techs or your clinical laboratory scientists to do a lot of other things in the laboratory. You have that decreased work in process, so you don't need to read your negative plates for days and days. And then ultimately, you end up with a simpler protocol that's easier to implement because you get the same test irrespective of age, blood in the stool, etc. And I think that the VERIGENE EP assay addresses these problems because it gives you one test for nearly all community-acquired pathogens, high sensitivity and specificity, fast turnaround time for clinical interventions, cessation of inappropriate or potentially even detrimental therapy, more timely implementation of infection control measures, and it's also, importantly, moderately complex and compatible with a wide range of med tech experience. And with that, I will turn the presentation over to Marilyn to talk about their experience implementing this assay at their institution.
Hello, moving on to the next section of our presentation, I am very happy to be able to discuss with you the process that we went through in deciding to move forward with...
Marilyn, just going to quickly interrupt. We're just not seeing your slide yet, so just accept that pop-up just like we practiced. Perfect. We're seeing that now. Thanks.
Okay, sorry. I want to talk to you about the process that we've gone through in deciding to move forward with molecular testing. So we are a fairly large hospital in the Central California area. We have about 1,000 hospital beds in our system. And we have a really active emergency room. We're a level 1 trauma center. And we have an active outpatient center also. So we use several molecular methods in our laboratory for different types of testing. And so we wanted to put our stool culture bench up to that closer evaluation. And the question, of course, we ask is, would that be an improvement to patient care? Because after all, that's kind of what we're about here. And so our answer to that, as we carefully looked at it, would be yes, of course, because it's going to give a lot faster results as well as being very sensitive. So one of the main things is that a molecular panel is going to be able to be completed within just a few hours. And in addition to the detection of the bacteria that we're used to culturing for, we will also be able to report some of the important viral pathogens that is causing the diarrhea. So, in fact, just as a side note, during our verification process, when we were using, you use some negatives, some positives, and we actually, of the negatives, we had 2 positive norovirus and 1 that was positive for rotavirus, and those would not have been or they were not ordered, and so those were not results that the doctor was considering in their diagnostic questioning there. So the the molecular panel just takes a few hours. It's obviously faster. The culture method takes up to 72 hours to finalize your CAMPI plate, which is part of that. And then if the CAMPI plate was positive, you actually have additional delays. And we tried to analyze the method for the CAMPI to see if we could improve our turnaround time. And we weren't real happy with the results on that, so we did return to the culture method for that. So another big issue that plays into our decision here is a concern about staffing. And I know a lot of laboratories are going through the same thing. We're struggling with the issue of retiring CLSs and also increased workload that we're seeing. So those are not a good combination. So we wanted to make sure that we were not adding in more work for our department by adding in a molecular method for the stools. And we wanted to be able to actually replace the stool culture bench. And so that would be probably the only way that the staffing issues could be improved. So if we do that, we're hoping as we go forward then that we will be able to make better use of our CLSs and use them more for mentoring and support for a lot of the newer CLSs, and also increase our ability to have better method validations and have better competency monitoring. But the training and being able to use the experienced CLSs for more help of the less experienced ones, those are always big pluses. So we looked at the big picture. We decided that we would check out the stool culture bench as this opportunity to improve our workflow and to give us more time for the goals that we have in our department. So we test over 2,000 stool cultures a year. So that means about 6 to 10 new cultures each day. About 10% of these are positive for Campylobacter, Salmonella, Shigella, or Shiga toxins, and rarely we do see some of the other pathogens also. So 3 of the main parts that go into the stool culture are setting up your media. We use the blood McConkey and AG plate, and those get incubated for 48 hours. We look at them at 24 and 48. And then the Campylobacter culture is a separate plate. It has separate incubation conditions. It gets its own incubator at 42 degrees, and then it also uses a special gas pouch in this closed box so that it has the right microaerophilic environment. The third main part of our testing is that we also set up a MAC broth, and that gets incubated overnight, and it's used for the Shiga toxin testing the next day. And we use the immunocard stat EHEC test using that McConkey broth. So our lab assistants are the ones that set up the initial media, and they set up all the various plates needed, but they go into 3 different incubation conditions here in our lab. The CAMPI plate, of course, goes into the CAMPI CVA plate. It actually goes into the 42-degree incubator, and then it needs that separate closed box. We use the Mitsubishi boxes, and then a separate the CAMPI gas pack to provide that proper growth environment. So then the second incubator is all the plates get put into the regular CO2 incubator, and then we put the McConkey broth into a non-CO2 incubator. And then in addition to putting the plates and setting them up and putting them in the incubators, they also have to monitor the temperature for the CAMPI incubator, which the only use for that incubator is for the stool cultures. Otherwise, we would not need that incubator at all. The licensed CLSs perform the evaluation of the plates at 24 and 48 hours. They're evaluating the McConkey and AG plates. And so they're looking for suspicious growth of the pathogens. And if they find that from those plates, they would set up a urea testing of the suspicious colonies, and then that is incubated an additional 6 or 8 hours. If it's positive on the urea, then they have ruled out pathogens except for Yersinia, and that would need additional workup. But the urea negatives, then, you would need to set up a KIA, and we go straight to the Vitek gram-negative card. It seems to be a smoother workflow for us instead of doing some of the additional manual testing. So we end up setting up the ID card for colonies that are urea negative, non-lactose fermenting, that we consider suspicious for Salmonella and Shigella. And since we are going straight to the ID card, we do end up seeing several Citrobacters and E. coli that come up on this because they could look very similar. And so that does cost a little extra to do those extra cards, but for our workflow and staffing, it's a faster process to set those up. So then the next part of our culture workup is the Campy plate, and that you have to look at over 3 different days. And if there are suspicious colonies, then you would check those out using the oxidase test. If it's oxidase positive, then you would do the gram stain and look for the typical gram-negative gull-wing shaped organisms. And if you find that, then we would take that to the Vitek NH card for ID. And in addition, the CLSs then would restreak the QC organisms for Campylobacter every day because you have to make sure that even though you think you've got good growth conditions, you have to prove that you do. So the third part of the culture is setting up your rapid test for Shiga toxins. We use the lateral flow rapid test. It's very easy to do. The onboard controls work real well. But there are additional steps required when you use a rapid kit, and that would be that you have to maintain your new lot or new shipment QC, and excuse me, at least do quality control or the external quality control every 30 days. So one part of our current testing is that it takes a lot to have your inventory, keep it all straight. It involves quite a bit of monitoring. First of all, you have to make sure you have the proper proficiency testing set up, and we will no longer need to do stool cultures, which are included in the main D bacteriology survey. We'll continue with that survey, of course, but we don't have to do the stool culture part. And then the Shiga toxin is part of another survey, and we may or may not need to keep that one because that also has C. diff on it. So you have to make sure for yourself that you have the right proficiency testing, probably not a big decrease in that testing. But where we really see the improvement is with the different media and reagents kits that are involved in cultures. So the Campy CVA and MAC broth, for sure, we would not be needing those. We don't need the Campy gas packs. Some of the miscellaneous tests, we probably would not need the KIA slant, and probably we would not need to continue. Well, for sure, we don't need to continue with our rapid EHEC lateral fold test for the Shiga toxins 1 and 2. So that in itself is a big help to improve inventory management. So as we looked at the various molecular options, we looked at one method. We felt it had maybe too few organisms, and if we chose that method, then we would need to keep some additional testing as part of our stool culturing, and we felt we would not be able to completely do away with our stool culture bench. We did a verification process on that one, and it did work really well. We had no complaints at all with that instrument. And then we looked at another option, and it had more organisms on their panel than we wanted. And it was also awfully expensive for us at this time. And I'm sure it works very well. It's also a very reputable company, very good company. So we looked at the VERIGENE panel, and we decided it's really a middle ground, and it seemed to offer the proper choice of organisms. Our infectious disease physicians, we had them look at all the different options with us, and they liked the choices that were on the enteric pathogen from VERIGENE. So we already have our C. difficile testing covered on a different molecular platform, so we didn't really want it on as part of our stool enteric panel monitoring. We didn't want to have to deal with a lot of results on carriers, of people that are just carriers of C. diff, because we know that's out there also. We wanted only to be testing patients where they have the suspicion for C. diff infection. So then we want to look at, does molecular testing really make sense for our laboratory? So, so we were looking then at the time involved in our cultures. And it really does take a lot of hands-on time, and you have those cultures around for at least 72 hours. So you set up your culture, you review your plates 24 and 48, and then your Campy plates at 72. So even though you may just be doing 10 plates or 10 samples a day, if you keep them for 3 days, you're actually looking at 30 samples each day. So then you also have time involved in setting up and reading the miscellaneous tests of their urea, KIA, oxidase, gram stains, that type of thing. Also, we know that we set up more of our Vitek gram-negative cards than we really need to, but it's just the easier workflow for us, and so we have done that, and it, of course, adds expense to our setup. We use the NH card, Vitek NH card for the Campy ID. And then, of course, the time involved for setting up the rapid EHEC test. And you have to document each step as you're going for these 3 days of evaluating these slides. So obviously, there's a lot of expensive time involved in working up a stool culture. If we look at reimbursement, we also noticed that there is a difference there. We wanted to look into it thoroughly to make sure we understood it. So first of all, our stool cultures, the main one is the 87045 that covers Salmonella and Shigella. Then you get a couple other CPT codes for some specialized media, and different labs have different media that they set up. But these were our, this is our setup. So we were evaluating from our standpoint. Then the additional code for the sugar toxins for the EIA test, you get to put that in 2 times because you're looking for toxin 1 and toxin 2. So our total reimbursement was around $64. And what we're paying for our reagents and media and kits and some of the various things is about $21 per test. And so it doesn't leave a whole lot left, considering that you are monitoring that over 3 days and involved with your quality control and all those various parts that do fit into your hands-on culturing. So probably the reimbursement is borderline for covering the cost of our stool cultures. So then we wanted to look at the molecular panel, and everybody knows that molecular testing always seems like it's really expensive. Or at least the cost of a molecular panel is more than the cost of your basic media plates. And so we wanted to really lay this out and know for ourselves what we were doing. So the CPT codes for the stool pathogen panel for the nanosphere panel is the 87506. That one looked like it would be the best. And that covers 6 to 11 of your gastrointestinal targets for this multiplex assay, and the reimbursement's around $290. And then if we take cost of the nanosphere reagents, it's around $80, and again, that varies by your testing volume. And then, of course, you can't forget the Carey-Blair preservative tube that we would need, and that's it's a little under $1 for us. I don't know, it probably varies quite a bit, but that's not a big expense. And so the remainder of the leftover reimbursement is adequate to cover some of the proficiency testing, quality control, and also for the employees' time to do testing. Does much better coverage than what we get for the culture. So then again, I wanted to list the bacteria, viruses, and toxins that are included on this panel. And these are the main ones that we would want to culture for. And our ID physicians were really glad to be able to have testing for viruses included now. They like the idea of norovirus being there. So I wanted to step through how simple it actually is to set up this testing. First of all, the stool sample would be placed into a Carey-Blair vial, and as I said, this is probably less than $1 for that vial. And then if you're not ready to test it, it can go in the refrigerator if you wanted to test them later in the day. But we usually would just put it into the vial and then go ahead and test from the vial right then. So you would then take a swab that's provided in the kit, and you would dip it into your Carey-Blair media, put that into your buffer tube, which is part of the kit also, break it off, vortex it real briefly, and then a quick spin, and then your sample is ready to go, and you would use 200 microliters of that to load onto your VERIGENE sample processor. On the left, it shows a picture of the various consumables that get used for this testing, and then on the right it shows loading the 200 microliters of sample into the sample well. And then really all you do is press that little black button, the arm goes in, and your testing takes about 2 hours. So that's really all that's involved. So the results get reported. For us, 90% of our results are negative. So we would report that as none detected and list the samples from the panel that are considered none detected. And then if a result is positive, and I need to add in here, 75% of our positives at our facility are actually Campylobacter. Probably others have different results, but that's what we have. So there are very few that need any further workup. So if it does become positive, you'd have that same day. You'd go pick up your Carey-Blair that you had set up initially, and you'd streak that out for susceptibility testing. And you would want to, you have to figure out for yourselves what would work better if you want to put that onto a McConkey or HE, or anyway you need to get it onto your blood agar plate to set it up for susceptibility. So then we need to remember our public health department. They need reports on all of these stool pathogens that we're doing. The viruses only get reported to our public health if we are in an outbreak situation for rotavirus and norovirus, but we would be able to pick these up a lot faster because they are now currently done here instead of being sent out. So we would be able to alert the public health department faster. As we go live on any new test, we need to have a plan. And so I wanted to go through some of the steps of the plan that we use, and maybe some of you will find this helpful too. So you have to do your initial verification, validation process to show that the test works well in your laboratory also. And so we would be testing this for accuracy of our test results. You would compare this against your reference method. You would use a mixture of positive and negative samples, and we use some patient samples, some spiked samples, some quality control samples. So you complete this process and you present it to your pathologist for their agreement or their input if this is acceptable for patient testing. Then you have to put your procedure into your document control system and get it signed off by the pathologist. Have the staff read and discuss, give input on this new process and your new procedure, and make sure that they're trained to perform the testing and also on how to report the results that come out of the nanosphere. We like to report or write up an article for our physicians' newsletter. They like to be kept informed. So that's one of our steps of our new test plan. So we then also need to get the test built in our lab computer, our hospital computer, and make sure that it's properly added to the hospital charge master. And have in the computer, we want to make sure our proper isolates are marked for public health department so those reports get sent appropriately. And then make sure you have the proper proficiency testing ordered. So those are some of the steps that we make sure are in place. So then I just wanted to go through a verification process. This is an FDA-approved method, so that does help a lot as you're moving forward. So what we did was we initially, as our samples from stool cultures were coming in each day, we put all of them into Kerry-Blair media. And then if the culture was positive, over the 2 or 3 days that we monitored them, we would pull out the Kerry-Blair vial and test it on the Nanosphere EP panel. And that worked. We didn't have any discrepancies at all on that. We also spiked several negative samples, and I have another slide for that just coming up in a minute. I think that's our next slide. And so then we tested a lot of culture negative samples as part of our accuracy to show that we had good specificity with this method. Several specimens we also used as a reproducibility or considered a precision study, and that is picking several samples, positive and negative, and have them repeated by different operators and over 3 to 5 days to make sure that you're getting the same answers in those varying conditions over different days and with different people. And as usual, this was just fine. We had no problems with that. One of the things that we found it is very helpful is that Zeptometrics has an enteric pathogen QC panel that meets exactly the pathogens in the Nanosphere panel. So you get all of the different bacteria, the toxins, and the viruses all within this panel. So that was very helpful. And in addition, we will be preparing, or we have prepared some of our own QC panels from using our own pathogens in our hospital. So another part of the verification process for us, or at least the going live process, is that we want to perform a 20-day QC process using the external QC to show that that the onboard QC is working properly every single time, and we don't want any problems with that onboard QC. And so you want to do that to make your life easier down the line. That way you can switch to the new lot, a new shipment QC, or and the every 30-day QC. So that's a valuable part of your go-live process and well worth the time. So then just quickly running through what we use for our verification. We put our regular stool culture samples into the Kerry-Blair, and then also we saved a lot of our stool cultures from previous samples. We keep everything. I think maybe that's being microbiology people, I don't know. But we keep all of our positive isolates on slants for several weeks. So we had kind of an accumulation of slants with positive Salmonella, Shigella, Campi, whatever. So we restrict these positive colonies to get fresh growth. Then we made McFarland standard. We had prepared some culture-negative Carrie Blair tubes with actual stool in it, then pipetted 100 microliters of the 0.5 McFarland into that and mixed it up well. And then we had by doing that, we had some additional positive samples of actual organisms from our patient samples. So then in addition, we used the Zeptometrics QC panels, and especially this was good. Well, it includes all the pathogens on the nanosphere panel, but it also includes viruses, and it has the Shiga toxins also. But those you don't have to put into Carrie Blair. You use them just directly from the little vial that comes in the set. So just to wrap up here, just wanted to quickly say that this VERIGENE system provides us with, it's a sample to result platform. It has actually 2 steps, I guess you can say, but the main thing is that all the testing is performed inside the processing tower. Once you load that 200 microliters into that, it goes until that part's all done. Then you take, and it loads onto this testing cartridge. You take the cartridge out and slip it into the reader, and in a couple minutes it prints out your result. So it's very simple to do. It takes less than 5 minutes of hands-on time, as opposed to the culture had a lot of hands-on time. It is a moderately complex test instead of the high complexity that is the stool cultures. And so we were very happy with that choice, and we feel that we have made a good choice. And I think going forward, we will still be happy with this as we move forward from the next several weeks and months. So now I am ready to turn the slides and the conference back to Andrew. Thank you very much.
Great. Well, thank you so much for that, Marilyn, and also thank you to Dr. Pieper for his portion of the presentation. At this point, I would like to invite our audience to continue sending their questions and comments, and right now using that questions window for this, which is the Q&A portion of the webinar. And I've already received a lot of questions here, so let's get started. Our first question to either of you: what is being done to ID Plesiomonas and Aeromonas? Are labs utilizing molecular methods still setting up cultures to ID these? Your thoughts?
This is Dr. Pieper. I think that's a very good question. I think that, when you look at the spectrum of molecular solutions that are currently available, there's one manufacturer that's Plesiomonas, but that's it. And so I think that if that is a concern for your providers and if that's a concern for your laboratory, you're still going to have to do some degree of culture for that. And whether that's, once again, depending on what your demographics are and what your ID providers and GI providers are interested in, that's a conversation that I think you need to have with them. We don't see that much of that, obviously, or I shouldn't say obviously, but we don't see that much of that, so that it hasn't strongly entered into our thinking. But we will be, we have discussed that with our providers.
Great, thank you for that. Go ahead, Marilyn, if you have something to add there.
I'm sorry, this is Marilyn piping in on that also, and we have the same kind of a setup here. We were a little bit concerned on some of those, but then as we realized that we only ID those if they are predominant or pure culture on those isolates, but we would still be able to offer that if a physician feels that that is something they want us to test for.
Okay, excellent. Thank you both for that. Our next question, a little bit lengthy, so pay attention as I read through this. This audience member says, we are in process of implementing an EP panel in our facility. We found during validation that we had a high number of norovirus positive patients that we would have missed previously, so we're happy with the switch so far. How are you handling sending isolates to your state lab for reporting? Our state lab wants us to continue to ship isolates for epidemiology purposes, but our projected savings included no longer specialized media to isolate specific bugs. We offered to send specimen in broth for them to isolate what they're not happy with this suggestion. So basically the question, how are you handling sending isolates to your state lab for reporting?
This is Marilyn again, and we are probably spoiled by our local Fresno Public Health Department. They said that they would be okay with us sending them the broth. But we will continue to grow up some of the organisms that need to have susceptibility testing. So we will maintain some of our media here, but it would be a very, very limited number that would have to be grown up. But our local county public health will take the broth.
That is the same approach that we are going to have here. Our state has communicated that they will not require us to send them the actual isolates anymore, that a broth or a carrier would be adequate. But we will continue to have some of the specialized media on hand in very limited numbers to assess for these pathogens if they're positive on the molecular panel.
Great. Okay. Well, thank you both very much for those answers. In respect for our speakers' time, we have reached the end of the question and answer portion of this webinar. If we weren't able to attend to your question today, our speakers or the team at Nanosphere may be able to follow up with you and your question via email. If you do have any further questions, however, you can please direct them to the email address showing on your screen right now. That's webinar@nanosphere.us. And thank you, everyone, for participating in today's conference. You'll be receiving a follow-up email from X-Talks with access to the recorded archive for this event. And a survey window will be popping up on your screen. Your participation is appreciated as it'll help us improve our further webinars. Now, please join us in thanking our speakers for today, Dr. David Pieper and Marilyn Mitchell. We hope that you found this conference informative. Have a great day, everyone.